Introduce Elisa DeVargas, Ph.D. is a licensed psychologist at the University of New Mexico Child Psychiatric Center, where she provides outpatient psychological services at the Programs for Children and Adolescent Clinic. Dr. DeVargas specializes in the provision of Spanish language services, couple and family therapy, and child and adolescent mental health. Her clinical interests include child and adolescent development, parent skill training, trauma-focused intervention, and family therapy. Her research interests include substance use prevention, cultural adaptation of EBPs, treatment outcomes, program development, and Latinx mental health. Dr. DeVargas has a long-standing commitment to developing her Spanish language skills and providing culturally sensitive services to underserved populations. She is also actively engaged in the APA-accredited UNM Health Sciences pre-doctoral internship program, for which she serves as clinical supervisor to interns in the child clinical track. Dr. DeVargas completed her doctoral training at the University of Oregon with a Ph.D. in counseling psychology. She did her pre-doctoral internship at the University of New Mexico Health Sciences Center, APA-accredited pre-doctoral training site. And after completing her degree, Dr. DeVargas spent 8 weeks in Peru, where she obtained specialized training in Spanish for mental health, followed by a 1-year postdoctoral fellowship at the APA-accredited Southwest Consortium at the Raymond G. Murphy VA Medical Center. She has been practicing independently for almost 5 years as an employee of UNM hospitals. Thank you. And Dr. DeVargas, I'll go ahead and give the floor to you. Thank you for being here.
Thank you, Tom, and good job reading all of those different titles and weird names and acronyms and all that good stuff. Good afternoon, everybody. Let me quickly share my screen so that you all know what I'm going to be talking about. Oop, hold on. All right. Oops. I'm almost there. Here we go. Okay. Good afternoon, everybody. Me llamo Elisa DeVargas y soy una psicóloga bilingüe. Soy de Nuevo México y estoy aquí para hablar sobre mis experiencias como un proveedor bilingüe. So my name is Dr. Elisa DeVargas. I'm a psychologist here in Albuquerque, New Mexico at UNM, and I'm here to talk to you about my experience as a bilingual provider. First off, I would like to just mention, let's see if I can get my slides to work, that I don't have any financial disclosures to make. And this is our agenda for today. So I'm going to start with a brief introduction and then a review of the objectives. Whenever talking about issues of diversity, inclusion, and equity, I think it's always important to provide a good introduction so that you can understand my history and background, as well as why this work is so important to me. So I will spend quite a bit of time just talking about my background and my history. And then we're going to move into some information about New Mexico demographics as they relate to bilingualism, barriers to treatments for bilingual individuals and families, as well as discussing some best practices and general adaptations that you can walk away with today. So, ¿quién soy yo? I just saw that typo, but ¿quién soy yo? Who am I? I'm Dr. Elisa DeVargas. I'm originally from New Mexico. I'm New Mexican through and through. As my Norteña friends would say, I'm from New Mexico all my life, and I'm very proud to be a New Mexican. I identify as Chicana, and I grew up with a Spanish-speaking family, but I did not grow up speaking Spanish. And so the idea and issues surrounding language have always been on the forefront of my brain. Growing up, I always felt like I was at a disadvantage and had a feeling of loss because I didn't understand what some of my relatives were talking about, and I wasn't able to communicate with some of my relatives because I didn't know Spanish. But I've always spoken Spanglish, And so gradually those skills kind of improved and increased throughout the years. And then in undergraduate, I did a double major in Spanish, and that's when I really started to hone in my language skills and improve my Spanish to the point that now I'm able to provide services and speak relatively fluently. Although I think as a second language learner, it's always a growth area, and I'm always like counting my milestones. So one of my biggest milestones this week was providing therapeutic feedback to a family on a really complex diagnosis that I've never even diagnosed in English, much less having to describe it to the family in Spanish. So I've been studying Spanish for years, but I'm still constantly growing, and I'm always trying to learn better ways to serve my clients. I also have a background with working with immigrants and refugees. So before I was at Programs for Children, I worked at the UNM Southeast Heights Clinic, where I worked primarily with immigrants and refugees. I worked quite a bit with the Cuban community, as well as with some of the Afghani refugees, Vietnamese refugees, and others. So thinking about UNM, as I was putting together this presentation, you're going to see that a lot of my focus is on Spanish speakers because that's where my specialization is. And I want this to be inclusive of all the different languages that we may see throughout the time that we work within UNM and just here in Albuquerque and New Mexico in general. So please feel free to interrupt me if I'm honing in on Spanish-speaking populations and you're wanting to get an idea of like, well, what would this look like with another population? Definitely raise your hand or unmute yourself and we can have some further discussion about what that might look like. We're also going to talk a bit about interpreter services because that's a really key component in working with folks who have multiple languages that they speak. Let's see, what else do I want to say about myself? I think those are the biggest pieces. One of the things that I would add is part of my growth has included a lot of cultural studying. So not just of the language, but traveling, integrating myself into communities, and going out into our local community to try to learn from those who live close by. So those are going to be some of the things that I also discuss as a way of building your cultural competence and your ability to serve bilingual folks. All right, let's talk about the objectives. So we've got 3 primary objectives for today's presentation. First is I wanted to talk specifically about New Mexico and the sorts of language nuances that we observe here within our populations. I was going to include some trivia of some vocab words, and I just realized that I forgot to include that, but I might get a little bit, might go off track and include that anyways. And then the second objective is to be able to give an example of at least one cultural adaptation for working with bilingual folks, and then identifying 3 barriers that bilingual patients might face when trying to seek behavioral health and mental health services. So let's talk about New Mexico. I think we all know in the United States that there's just a growing diversity in our communities, and one of the biggest communities that speaks a language other than English is often the Hispanic Latino community. And living here in New Mexico, we have a unique experience where we live in a place where Spanish is actually one of the official languages of New Mexico. And so we see the integration of languages a lot more in even populations in New Mexico that don't identify fully as bilingual. So there's a lot of interesting things that happen with language in our state, and I think kind of draw out the unique beauty of where we live and how it differs from the wider United States as well. So first, let's talk about the state population. So we know that well, the majority of us, I think, know that we're a majority minority state, which means that the majority of our state population is made up of individuals who identify with an ethnic minority category. However, if you look at this breakdown here, you'll see that under the white race, it lists this as 81.9% of the population. So we're going to talk about why that looks so different based on what we know. But I would also like to highlight that aside from white or Anglo-American racial presentation, we also see as the second highest population of Native American and Alaska Native in our state. And then when we look even closer at New Mexico, you can see how this breaks down even further. So still with the white and Native American populations at the highest, and then a smaller breakdown as we go through the other racial ethnicities. And then if we break it down by Hispanic versus non-Hispanic white, this is where you can really see where we get that title of minority majority state. So when we look at that 81.9% of the state population, about 49.3% of those folks actually identify as Hispanic, Latinx, or in my case, Chicana. And then the other 36.8% are non-Hispanic whites or Caucasian, Anglo-American, however else we can categorize folks from European background. Then we take a look at Albuquerque, and I think, let me see, we had 73.9% of the Albuquerque population identifying as white. And then when we further break that down, we see that it's about 49.2% of Albuquerque's population that is Hispanic or Latinx. So I highlight these because the title of my presentation is I Speak Spanglish and Language Considerations in the Therapy Room. So oftentimes when I think of New Mexico and the languages we speak, Spanglish is one of the primary languages that comes to my mind because of where we are in terms of our generations of being part of the United States and how language shifts and morphs throughout those generations. So like I was saying earlier, there are a lot of people who may not even consider themselves bilingual, but they're using words that come from other languages and integrating them into their daily vocabulary. And so this is where it can become really fun and interesting to think about how we can infuse and use language creatively when we're working with patients in the mental health field. So additionally, I want to highlight that the other languages that we see quite frequently are native languages. So here's a map that identifies the various pueblos that are established in New Mexico. We have 19 pueblos, 3 Apache tribes, and then we've got the Navajo Nation. And there are much more language nuances and dialects, but what we know is that officially there are 8 languages that have been identified across these native tribes and communities. So the likelihood that you're going to come in cross paths with somebody from New Mexico who also speaks another language aside from English is going to be pretty high given these numbers. Both thinking about the Hispanic communities as well as the Native communities. And then if we look at the populations that we have here in Albuquerque, we have pockets of communities that speak a whole host of other languages. Just thinking about that, I want to see like what other languages you all have used in your clinical practice. So for myself, I haven't used it, but I've used an interpreter and conducted services in these languages. So I've done, let's see, Vietnamese, Dari, Arabic, American Sign Language, and Swahili, as well as there's one other one that's very rare and I can't think of that name, but put it in the chat if you met with a patient who spoke a language other than English, Spanish, or one of these other native languages. I actually, unfortunately, haven't worked with anybody who spoke native languages, although I have lots of friends who do. So I see Navajo and Dene. Yeah. Anybody else? Feel like being a part of UNM gives us the unique opportunity to interact with these communities that, you know, other folks across the state don't get the opportunity to do. Yeah, Twi, a language in Ghana. Ooh, I wonder if that's the one I couldn't remember. And then Vietnamese. Okay. All right. So what we can see here is there's like a lot of experience. Kurundi and Lao. Okay. Yes. So when we're using interpreters, usually we're using those with folks who are monolingual speakers, but then we also have the cases where there's bilingual folks, and that might include family members, younger kids, or folks who have been in the United States for a much longer period of time. So just kind of going back to New Mexico and the languages that we see here, what we know is that of the whole population of New Mexico, about 32.6% of the population speaks a language other than English at home. So that can include any language. And then when we narrow that down to the New Mexican Hispanic population, we see about 50.1% of those folks speak Spanish in the home. This also doesn't include any information about like native languages from Mexico and South America and Central America. And so many times we're also seeing folks who are multilingual, who speak more than 2 languages and are navigating the challenges of that. But before we talk about challenges and barriers, I think it's really important to notice that there are such huge benefits of being bilingual. And I think that's one of the things that I want to really highlight today is that bilingualism should not be viewed as something that's scary or intimidating. It's something that can be really beautiful and helpful in the mental health field in relating to your patients and connecting with them on a deeper level. So even if you don't speak another language, you can use your words and your language strategically to build connections. And that's my hope for today, because we want these beautiful bilingual, multilingual folks to really embrace that part of their identity and know that that's something that they can bring to their treatment. Oh, I see Arabic, Farsi, and Chinese. Yes, so lots of different languages. All right, I'm trying not to go too fast because I realize that I'm a little bit nervous. Let me check my time. Okay, I think I'm doing okay. I'm not rushing too much. So the other pieces to think about when we're talking about language and mental health is that language is one of our key and primary modes of obtaining information from our patients. So if we're relying on language and we do not speak the language of our patients, that could create a huge challenge for both of us. Bilingualism presents special concerns to consider, even if you are using an interpreter. And it's important to note that most people who are interacting with folks who speak another language other than English are probably not bilingual or fluent in that other language. There's a huge disparity and lack of training and providers who are multilingual and bilingual. So according to a study done in 2018, approximately 11% of mental health providers stated that they actually provide services in a language other than English. That's across the United States. So if we think about 11% of the mental health field being able to provide services in a language other than English, that just highlights how huge of a gap there is in folks who speak other languages obtaining mental health services, as well as working with a provider who maybe shares that language knowledge and fluency as them. And then bilingual clients may experience their emotions and memories differently depending on the language that they're using, and that can significantly impact progress in their mental health treatment. So the other things to consider are if a person has a primary language or a native language, but is fluent in English, how can you use those other language skills to build rapport and help the client engage in self-reflection that's going to help them meet their treatment goals. And then also thinking about bilingual folks, we often like to kind of play with the language, and it can depend on our moods. And so individuals who speak more than one language are often toggling between those two languages and code switching throughout the time that they're engaging in conversation. And so to be an inclusive provider, I think it's important to understand how to create an inclusive environment so that your patients can play around with the language, even if you're not exactly sure or fluent in that language. How can you encourage them to own that identity, use that space to explore, and then engage in your own learning so that you can support them in doing that? All right, we're going to move to barriers to treatment, but I do want to take a quick little pause and see if there's any thoughts or questions so far. I do tend to like to include a lot of discussion and engagement from my audience, but I also recognize that we have a short period of time. So just take a quick pause. All right. So my guess is that you all can think of some barriers to treatment. So let me hear from you all. What are some things that you can think of right off the bat that can come into play when bilingual or multilingual patients are trying to seek mental health care? Length of the appointment times, yeah. So when I hear that, what I think about is that, you know, an hour-long appointment might feel infeasible or unfeasible for folks who are working and who maybe cannot come in, or who maybe their language skills aren't proficient enough to engage in conversations for that length of time or in that depth. Yeah, establishing and building rapport, psychological safety, trust, racism, yes, all of the unconscious biases that come into play, navigating the healthcare system. How do you schedule an appointment if you can't speak the language? Understanding concepts or figuring out how to describe those terms without losing it in translation, yeah. The ability of the interpreter to understand their specific dialect. Oh my gosh, that came up so much with my Dari speakers and my Afghani refugees, because there's so many different dialects. Yes, family discussions. If family is involved, that involves a whole other level of language skills. Yeah, availability of materials, having to make multiple plans and do extra work because you're trying to work with those other languages. Yeah. Awesome. Thank you. I think you all provided probably a much more extensive list than I did. But my goal was to kind of get your ideas as well. So I started to address barriers to treatment by thinking about language proficiency. Yeah, children serving as interpreters for their parents. Oh my gosh, that's such a big problem. So when there are language proficiency issues, like say a parent who's monolingual Spanish speaking or other Vietnamese speaking comes in and they have a relative with them, that can create some dynamics and potential ethical issues or other considerations, right? But it can limit their ability to get into treatment, either because they're having to wait for a provider who is competent in treating them, who has the language skills, or because there's just a long wait list for folks who are needing that type of service. So I can share from my experience that within the clinic that I work, patients are often waiting for me because up until recently, I've been the only Spanish-speaking provider in that clinic. And so it can mean long wait lists or just delaying treatment because they don't feel quite trusting of the healthcare system or able to access it. And then also there's experiences of inadequate care. If a person speaks the language or doesn't, and also doesn't understand the culture, that can lead to microaggressions, discrimination, prejudice, and then also just like misunderstandings or misdiagnosis, which can also impact the adequacy and quality of care. If a person is misdiagnosed and they're being treated for a diagnosis that they don't actually have, it's unlikely that they're going to see progress and feel like therapy or mental health treatment is actually benefiting them. So if we think about these barriers as well as like how people view and engage with services, this could potentially prevent them from re-engaging even if they seek services initially. And then there's just a history of people who speak other languages aside from English underutilizing psychiatric services in general. And part of that is because there's such a reliance on language for providing those services. So many of the people who speak more than one language in our communities are going untreated, which I think is a big problem. And then we have the issue of the lack of training. So typically, when I've attended multicultural competence trainings, there's rarely ever a focus on language, not even like a focus on slang, right? It doesn't necessarily be like, okay, you got to learn this new language and become fluent in it, but like, what's something that could be cultural, like slang that we could talk about? And I think that's something that's missing from most of our multicultural competence trainings. We also have few training programs throughout the United States that have the structure and resources available to provide the training of bilingual providers. So one of the things that I forgot to mention in my introduction is that I'm currently a part of a task force that is developing guidelines for bilingual training in psychology. This is going to be bilingual training in general, but we are a team from the National Latinx Psychological Association. So of course we have our hearts set on our Latinos population and Spanish-speaking population, but hopefully these guidelines will help inform how training programs can support students who are interested in building their language skills and in being able to offer services in a language other than English. But right now, there's a huge lack of these sorts of supports. And then the knowledge of two different languages does not equate to the knowledge of culture. And this is something that many training programs, employers, fellowships don't understand. So they hear that a person speaks another language, and then they kind of assume that they can provide services in that language. And that's not necessarily the case. And providing services by understanding treatment modalities is one thing, but then when we think about psychology, mental health, and the use of language, all of that is not in its own little bubble outside of culture. Culture is a big piece that needs to be understood in addition to the language and can create often challenges and ruptures to the relationship that then impact the patient's engagement in care. And then finally, because I work with kids and families, I thought it would be important to talk about working with kids in vulnerable populations. So when I talk about vulnerable populations, I'm thinking about like elderly, disabled, folks who typically have a caregiver who helps them out. So individuals within the same family might have different language abilities and also different educational backgrounds. And so thinking about working with children and vulnerable populations, we also have to think about how we can meet the needs of their caregivers, because if we are trying to treat the kids or these other populations and we cannot include the caregivers, we're likely to be missing a big piece or falling flat in terms of the interventions that we're giving. And then we need to think about how the children in vulnerable populations often rely on their caregivers to report their clinical histories. And so if we're not able to communicate with caregivers effectively and provide a space where we seek to understand them, not only verbally through communication, but also culturally, then we can have an inaccurate conceptualization of what's really going on with the family. So when I talk about this sort of stuff, one of the things that comes up for me is an experience I had with a bilingual assessment that I did, where a child was referred for an ADHD evaluation. They had a previous diagnosis of ADHD, but were previously assessed by somebody who didn't have bilingual abilities and who used an interpreter. So this child came in for a second assessment, and by working with me, doing a language assessment and also assessing some of the cultural pieces, what came to light is that this child didn't have ADHD. They actually had intellectual disability and were lacking in their ability to communicate in general in both languages, but also in their ability to understand and be able to report their own symptoms. And this was a big oversight from the initial provider who had evaluated them. And I think it was partially due to some of the language barriers. So that's one of the cases that always comes up for me when I think about the importance of both understanding the language, but also the cultural pieces that are important in understanding psychiatric disorders. I, as a therapist, love working with families, and I think it's a really, really great way to work with children and people who have limitations. However, this can be a really big challenge for folks if there's a monolingual speaker who doesn't speak English, and if the child or the other person you're treating is not able to effectively communicate with that caregiver. So in some cases, I often serve as like a language broker between the child or my patient and their caregiver. And if there is a lack of knowledge about language or how to use interpreters effectively, that can create a big barrier for family members and caregivers to participate in the treatment of these vulnerable populations. So you all listed a whole host of other barriers. These are some of the ones that I identified, but I definitely think that it's important to think about like the lack of resources in our state and in general that are translated into other languages, having to take more time and having more expectations of providers who do speak more than one language. And then also like really figuring out, how do I use an evidence-based intervention if it hasn't been normed or adapted for use with this population? Is this effective? Is it even appropriate? And how do you make those decisions? So let's talk about some best practices. Yay, I'm doing good on time. All right, best practices and cultural adaptations. So best practices. If you are working with a bilingual person, I think it's extremely crucial to have discussions about language first and foremost when you start treatment with that person or when they're added to your caseload. So if you know that they speak English as well as another language, just because they speak English doesn't mean that you should automatically assume that they're going to want to receive their services in that language. So I think that's one of the biggest mistakes that I notice people making. And even if they say, I prefer English, I think it's still important that you assess, well, how can you incorporate some of those other language skills in therapy so that if that feels like something you need to use to express yourself, you have that available, right? So using an interpreter when necessary, but if the patient is like, no, I can understand, you can try to work with them on that, but also use your clinical judgment and say, okay, we're going to be engaging in a really emotional conversation. I want to have this interpreter here just in case you want to express yourself in a different way. So having those open conversations, giving a rationale if you do decide to use an interpreter against what the patient is requesting, because that can also feel like you're undermining their own language skills and where they're at in their language development. And for many people who are learning English as a second language, they're very proud when they're able to speak those skills, and it can feel like you're offending them if you automatically assume that they need an interpreter based on their accent or the way that they speak English, or just based on the fact that they speak another language. Yeah, so I see a question in the comments of like saying more about changing from one language to the other when doing therapy. So we can talk about that a little bit more as we get into some of the like cultural adaptations, okay? And then I can also just share specific personal experiences of how I do that. So other pieces are trying to collaborate with interpreters when you are using them. So most interpreters are trained, especially in my experience with UNM, they're trained to work with medical professionals. But in our role as psychiatric, psychological, mental health professionals, we have a slightly different role than medical professionals have. And so it can be important to collaborate with your interpreters and talk to them about the nature of the sessions you're going to have, what your expectations are of them, and then also making sure that they're upholding appropriate boundaries and communicating things appropriately. Given that they're not trained in our ethics, we need to make sure that they understand what that means and how it differs from other professions that they may be used to providing interpreter services for. And then, of course, engaging in self-reflection is a huge piece. So if you notice yourself getting nervous about working with somebody who has multiple languages and abilities in that area, it's a good idea to reflect on that nervousness. But also, like for me, I feel relatively confident, but I'm constantly reflecting on what could I do differently and how is this person different from my frame of reference that I have in my mind. I think it can be so easy with cultural competency to kind of make generalizations and try to treat populations, groups of people in the same way, but we have to be aware that everybody comes from their own cultural context, and being humble and aware of how we may miss certain things is a really crucial component of working with folks who use multiple languages in their lives. I also encourage folks, if you don't speak the language, or even if you do, I'm constantly looking up words, look up the words that are frequently used and try to use those or incorporate them into therapy so that even if you're using an interpreter, your patient is going to hear you trying to speak their language, and that's going to help you increase your rapport building with that patient. So one example of how I've done this is when I was working with a Dari speaker for about a year and a half, and I learned how to greet her in Dari. And so when I would greet her in the lobby, I often wouldn't have the interpreter. I would have the phone in my office, and we would walk really silently through the hallways. And I knew I felt uncomfortable, so I was like, well, of course she's gonna feel uncomfortable. Like, what could I do to try to make this a little bit better? So I literally watched a YouTube video on repeat of how to introduce myself and greet myself in the appropriate cultural way with that person, especially as a woman, and greeting another woman. Because in English, we don't change how we greet people based on their genders, but other languages do, or even based on their social status. So we need to be aware of those things and look those things up so that we can meet our patients as close to where they are as possible, even if we don't have those language skills. And then I mentioned this, encourage code switching. So if your client is like in a mood and they like start speaking another language, you kind of might be there confused and uncomfortable, but I wouldn't say like, hold on, I don't understand. I think you need to be patient, let them express themselves, and then you can comment on body language. You can use your observations to engage them and see if you can kind of pull out the context of like, ooh, I really heard a lot of emotion in what you just said. And yes, I don't understand you, but wow, I felt that in my core. Tell me what it is you are wanting to express by saying that. So it's not going to shut down their use of that language. It's going to validate it, hold you responsible for noticing their emotions through their nonverbals, and then inviting them to connect with you through that. And then again, practicing cultural humility. Just because I've been working with Spanish speakers throughout my career doesn't mean that I know everything about Spanish speakers. And so I'm constantly reminding myself that I need to continue learning both about myself as well as the populations in which that I serve on a regular basis. So the practice of cultural humility is really recognizing who you are as a cultural being, how you present in the room with your clients, with your patients, and how all of those things interact in the relationship between you and your patients. This is also a practice of reflecting on your own cultural competency, both in understanding your culture and the cultures of those folks that you treat. I like to highlight that it's important to understand your own culture, because if you don't know or understand your own worldview, it can be really easy to make mistakes and have ruptures in your relationships with your patients, even if they have the same identities as you. So when we're working with interpreters, these are some of the guidelines that I've learned about. So trying to really provide psychoeducation to the interpreter. I talked about this a little bit already, about the nature of the relationship, the boundaries that are formed in psychotherapy, and how mental health treatment works. So that may include the length of the session. If you think about medical providers, their meetings, their visits with their patients are 10 to 15 minutes sometimes. Ours are about 50 to 60 minutes sometimes. And if an interpreter is not anticipating that, that could impact how they approach the interpretation and building the relationship with the patient. And then it's also important when using an interpreter to explore each member's role and expertise in the relationship. So therapy and psychiatric treatment often is a dyadic experience. However, when we're working with folks that have other language needs, it becomes a triad. And so you need to figure out how to communicate each person's role and how to make sure that the rapport building is happening through all three of you and not just between the interpreter and the patient or between you and the interpreter, because sometimes that may happen. So really thinking about the client as the expert of themselves, the interpreter, the expert of interpreting, and yourself as the expert on mental health. And then having ongoing discussions about rapport building among all three of you. What could I do as the provider to understand this patient better? That could be something you ask the interpreter, but also the three of you have that conversation together with the patient, providing their own insight, and the interpreter helping with some of the cultural pieces as well. And then meeting with the interpreter beforehand can be really beneficial. Again, one of the barriers that we talked about is providing services to people who have other language needs often is a time, takes a lot more time than meeting with our English-speaking folks. So this may not seem feasible, but it can be a really beneficial part of working with an interpreter so that you can kind of prep them for the session. This is also a way of protecting the interpreter from burnout because the type of work that we do can be extremely emotional and they come from their own cultural backgrounds as well. And so there may be things that they're experiencing as transference or countertransference, and that can be important for us to discuss as well. And then again, continuing education and ongoing cultural competence. So we can talk to the interpreters, ask questions about culture, and it's also our responsibility to continue that learning on our own, as the interpreter's job is to interpret. Do you all have any other suggestions for working with interpreters? I see a question. Yes, I've done therapy with interpreters and translators. I don't currently because I mostly work with English and Spanish speakers. And since I speak Spanish fluently, I don't need to. But I do have that ability where I currently work. Is it possible to give an example of two codes or code switching? I'm guessing that's what that's talking about. So code switching might be like switching between street talk and professional talk. It could be going between fully speaking English and mixing some words of the other language. It could also mean like really like tapping into who you are as a cultural being. So like it can include like even changes in body language as the person responds with their cultural context. So that like if you think about slang and how people's body language shifts if they're speaking slang with a informal group of people versus using more formal language with other folks. You can think about that as well as code switching. Yeah, so when I was looking at the guidelines for interpreter services, they did talk a lot about if the interpreter is the same throughout the treatment versus if it's a different person. I unfortunately pretty much always had a different interpreter, except maybe like with that one Dari case, I had one of the interpreters would be there pretty frequently, but not every time, like I couldn't count on it. So that was a challenge and I think probably impacted the rapport building. I think that when you're able to use the same interpreter, that can be a really, really beneficial thing for the relationship and the overall progress of treatment. But if you're using an interpreter that is consistent each time, you can build upon things and use those recommendations that I gave in the previous slide to really collaborate with the interpreter, like meeting before and after sessions and so forth. If it's a different interpreter each time, I think it's still important for you to spend at least a few minutes upon initially getting them on the phone or getting them in person to discuss what the patient is coming in for, rules of confidentiality, boundaries and limitations in the relationship in a therapeutic relationship, and so forth, because those folks, if you're getting a different interpreter, you may not be aware of their experiences with providing interpreter services for psychotherapy or for psychiatric care. So those would be my recommendations. All right, I know I'm getting short on time here, so let me get through this. So some cultural adaptations. So blending cultural traditions and beliefs in therapy. So this might, what this looks like in my practice is using a lot more religiosity or spirituality than I do with some of my other populations. It can include having them bring things from their cultural traditions to share in therapy as part of like maybe a transitional object or building tools for their coping. Providing handouts in both languages whenever possible. We talked about there being a lack of resources, and in my experience, there's such a lack of resources that are translated into multiple languages, but whenever possible, I really try to do this. And if I'm providing something in English to somebody who speaks another language, I will review it with them and then have them do some teach back or summaries so that I know that they're understanding the information that I'm giving them. One of the things that I've recognized through my work with folks who are not English speakers and who have immigrated is that there's variable education levels as well. So if we provide a handout that uses primarily written language, that may be really challenging because the person may have immigrated before they had formal learning in writing that language or reading in that language. And so even though they prefer to speak that language, they may not have the ability to read it and understand it in the same way as other folks might. So being aware of those things can be really important in figuring out how to adapt things culturally. If needed, I do use pictographs or nonverbal interventions. So using things like images to describe something in addition to words. Having role plays and trying to use skills in the moment with feedback live. And then for me, because I work with kids, but also when I've worked with adults who had like cognitive delays and things like that, using nonverbal interventions such as art therapy, music, things like that can be really beneficial adaptations as well. Including family members can be a huge benefit. We come from an individualistic training and society, and oftentimes our multilingual folks really rely on their family members, and collectivism is a big value, and so we have to take that into consideration. The DSM-5 has a wonderful cultural formulation interview that you can draw questions from to make sure that you're asking about culture and traditions and people's understandings of their own symptoms. And then also asking about whether or not they use traditional remedies or have beliefs about their symptoms, and trying to understand that from their lens and perspective first before trying to introduce your Western lens. All right, can anybody else think of other examples of adaptations? I know we're almost out of time. All right, so there was a question about using the language or kind of switching languages. So as the provider, if I'm using their language, like for example, with my Dari speaker, I started to pick up that seis did not mean six. It meant like that she agreed. And so like sometimes I would incorporate the language in what I was saying, or if I knew that I could respond to something directly that she was saying, I would like look at her and say the word in her language rather than relying on the interpreter to use that. And I felt like that was a really helpful tool in building my connection with that particular case. And then again, like if they are using language, like in New Mexico, we use a lot of mixing of languages. So like my panza hurts when we're talking about our belly hurting, or, you know, just things that you can incorporate where you mix in some of the terms that they may be referring to into how you're reflecting back, so that they see that you're putting forth an effort into really truly understanding what it is that they're saying. Hopefully I answered those questions. And then just as a summary, working with bilingual folks and multilingual folks is really complicated, but it's likely to increase throughout our professional careers. So I think it's really important that we continue to learn ways to support these patients and reduce barriers, especially thinking about the state and the context in which we live. All right, thank you.
And thank you, Dr. DeVargas. Such a wonderful presentation, very important for the context of our New Mexican communities. And so thank you once again for your expertise.
You're welcome.
Thank you.